Good afternoon, everyone. Thanks to everyone for joining us for this lunchtime CE seminar. This is a joint webinar offered by the New York State Council on Health System Pharmacists and then the New York State chapter of ACCP. So I'm really grateful for the collaboration between the two organizations, and really thank Nicole Sear-Hutcherson and Chung for their work on our planning committee, and certainly thank our speakers for being with us today. My name is Calvin Meany. I'm the current president of the New York State chapter of ACCP, and I have the pleasure of introducing our two excellent speakers today. So we are going to be talking about pain management in patients with substance use disorder. And so we have two experts in pain management and in substance use disorder to talk us through these two topics, and then go through some cases at the end of the patients with both of these conditions. So our first speaker is Dr. Ebtesam Ahmed. She is a clinical professor in the Department of Clinical Health Professions. She earned her Doctor of Pharmacy from St. John's University, completed a postgraduate residency at the University of California, San Francisco. She also holds a master's in bioethics from Columbia University. In conjunction with her faculty appointment, she's the director of the pharmacy internship for the MJHS Institute for Innovation in Palliative Care. She's a frequent speaker at major academic medical centers and conferences about pain management related topics to physicians, pharmacists, and other healthcare providers. She's authored many book chapters and peer-reviewed articles on pain management. She's a board member of the International Association of Hospice and Palliative Care, a member of the World Health Organization, EMRO Regional Palliative Care Expert Network, and a member of the International Narcotic Control Board, or the INCB, expert group on adequate levels of opioid consumption for medical purposes. So I thank Dr. Ahmed for presenting with us today, and she's our pain management expert on this talk. I'm going to introduce Dr. Bennett Doughty. He's our second speaker. He had his Doctor of Pharmacy degree with honors from the University of Connecticut School of Pharmacy in 2016. Afterwards, he completed 2 years of residency at the VA in Connecticut, specializing in psychiatric pharmacy. He joined the Binghamton School of Pharmacy and Pharmaceutical Sciences in 2018, where he's a clinical assistant professor in the Department of Pharmacy Practice. He also serves as a clinical psychiatric pharmacy specialist at the Guthrie Robert Packer Hospital in Pennsylvania, where he's created an integrated outpatient psychiatric clinic within primary care. He's a program director of the Binghamton University's Opioid Overdose Prevention Program, which is a state-sponsored program that supports training and distribution of Narcan to the university community. He's also the director of Binghamton University and SUNY Upstate Medical Center's Rural and Underserved track, which is a co-curricular track that aims to provide students with unique interprofessional experiences working with underserved populations. He's also a community engaged teaching fellow, which is recognized by the Binghamton University Center for Civic Engagement. Dr. Doughty's research interests are primarily focused on engagement of patients in their substance use disorder treatment and interprofessional care. He's board certified in pharmacotherapy and a board certified psychiatric pharmacist. So welcome to both of our speakers. Thank you so much for talking with us today. And I'm really looking forward to this presentation. And without further ado, we'll get started.
Great. Thank you so much, Calvin, for the invitation. And thank you for the panel committee who put this presentation together because it's such an important topic in treating pain in patients who have substance use disorder. So let's get started. So this is our financial disclosure. And here are the learning objectives for your own information. So let's start by defining what is pain. So according to the International Association for the Study of Pain, they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Pain is always a subjective experience, so that makes it a little bit tricky when it comes to treating patients, because there has to be a mutual respect and trust between the patients and the provider. Sometimes we know the source of pain in the sense of patients who are presenting with cancer, for example, or arthritis or diabetic peripheral neuropathy or an injury of some sort, but sometimes we don't really know the exact cause of the pain. Pain is an experience. Pain can be both physical and emotional. It's impossible to say that pain is only physical. Also, it's impossible to say that pain is only physical. And pain is subjective in the sense that whatever the patient tells us is actually whatever is happening. So it has to be, again, a concept of trust and trusting whatever my patient is telling me. There is no specific measure, objective findings that we call, there is no thermometer that we can use to measure patient's pain. There's all these scales that we're going to talk about in a minute, but there is no actual pain thermometer, like we say, or a specific lab testing or a specific imaging that can actually measure the quantity of pain. So the treatment, in summary, the treatment is going to be pretty much designed around an individual needs. Since it's not something visible, since there's a component of an emotional component associated with it, since it's a subjective experience, so it's pretty much going to be individualized based on the patient's experience, what worked for them, what type of pain they have, what medication they tried in the past, and so on. So when we think about the impact of pain, specifically in a patient who suffers from chronic pain, we use the term biopsychosocial model to explain the impact of pain on a patient. When we think of bio, we think in the how pain impacts our biology, so how the physical body is going on. So when you have patients who are experiencing severe constant pain, they are being less active, they are not getting in and out of bed, their joint becomes stiff, their muscles becomes weak. And as a result of that, they start to lose their stamina, they feel more tired, they experience low level of energy. And also as a result of that, from a psychology standpoint, or how pain impacts our psychological or our emotional health, patients develop stress or anxiety or anger or fear or frustration with the treatment plan. And then we see the social impact of pain on a patient in the sense that it starts to, patients could have negative thoughts or fear about the pain or the future, in the sense that they say things like, I can't do this, or I feel like I cannot get out of bed, or I can't do anything because of the constant pain. They start to develop negative emotions. They become depressed, or they have mood swings. They're becoming less active. They spend less time with their family and friends or engaging in any kind of meaningful activities that leads to distress, or increased disability, not being able to complete chores or not going to work, which further increase the stress and increase our overall pain experience for that patient. So chronic pain, in summary, affects all areas of your life, including how physically do you feel and how emotionally and how you interact with others as well. So when we look at what's the relationship between pain and addiction, so when we look at the studies and the published rates when it comes to addiction and those who have chronic pain, it's estimated to be about 3 to 19%. And there's what we call a synergistic relationship between pain and addiction. And this diagram here shows the back and forth issues between having constant pain and the risk of developing addiction, which makes it more of a complex issue. So as you can see here, pain may generate a loss of functional, which increases a patient's stress level, which also promotes maladaptive behaviors and thoughts leading to poor coping mechanism. This can also be a revolving cycles and eventually may lead to addiction or what we call drug-seeking behaviors or apparent drug-related behaviors. And we'll hear later from Dr. Bennett how addiction by itself is a chronic disease of the brain, rewards and motivation and memory related circuitry, and mentions how this could affect, how can relate it to the pain. So when you have pain that's not being addressed, pain that's causing functional disability, pain that's causing patients to have an increased distress, patients that's causing patients to be depressed and anxious, all or sleep disturbance and so on, this could lead into maladaptive behaviors on a patient's perspective and could eventually lead into addiction. So let's look at the causes of undertreatment of pain, especially in patients who suffers from substance use disorders. So what I like to call it, the barriers for inadequate pain management. So there are a number of potential causes. From an institutional practices, it's not uncommon for patients to present at a hospital with significant pain, but once the clinician starts to question the patients about their past medical history and they realize that the patient are on methadone or they're on Suboxone and Subutex, they become a little bit reluctant on how to manage their pain. And they feel like, oh, you're already on Suboxone or they're already on methadone, so that will address your pain. There's also the inadequate training and skills of clinicians when it comes to pain management. There is not proper teaching and training across the board in pharmacy curriculum and medical curriculum and nursing curriculum, and same also applies to addictions principles. Very inadequate training about what are the principles of addictions, how do you assess patients' risk factors for developing addictions, and not just pertinent to opioids, but addictions in general when it comes to alcohol and when it comes to other substance use. There is lack of also of access to healthcare. It's difficult to get patient into a good quality pain management for collaborative care. Reluctancy of physicians to prescribe opioids, specifically now in the era of we have of the opioid fear across the board. And there's also the reluctance of patients to seek medical care due to the stigma and fear of relapse, that maybe their addiction disease will relapse, or when is it appropriate to have an opioid of certain conditions. So all these represent like what we like to call it an ethical dilemma. Should you treat or should we not treat patients who present with pain, specifically if they have a past medical history of substance use disorder? So in order to treat something, I'm a very strong believer, and everybody should be, if you're going to work in pain management, that you need to understand what are you dealing with. So we look over here, we have the classification of pain. We have chronic pain, that's 3 months or more. And then we have acute pain, it tells you from the name, it's acute in the sense that it should resolve after time. So we see acute pain in patients who have post-surgical pain. So any patient who's undergoing surgery, or any patients who have had trauma of some sort, or any patients who have trauma in general, they will develop acute pain. And then chronic pain goes on and gets subdivided into visceral pain. So we see that in patients who have internal organ or like any kind of inflammatory bowel disease, or it could even be on a vascular level. So patients who have ischemia or migraine, or it could be a mixed. So we see that in patients who have cancer, or they have fibromyalgia or lower back pain. And then again, neuropathic pain, whether it's peripheral or central. So patients who have, for example, post-herpetic neuralgia or diabetic neuropathy, or they got cancer chemotherapy that resulted in peripheral neuropathy, or on a central level, patients has post-stroke or spinal cord injury. And the point that I'm trying to make here is that first, when you see a patient, you have to try to classify what type of pain are you dealing with. Are you dealing with acute pain, or are you dealing with a chronic pain? And also subdivide it in the sense of like, what is the patient feeling? So the quality of the pain. So a very important question to ask patients is, how does it feel like? To try to qualify, to try to identify what type of pain, so to tailor the treatment regimen around that pain. So for example, if someone has neuropathic pain, you know that, and whether it's peripheral or central, you know that you're going to have to give them like tricyclic antidepressants or SNRIs or SSRIs and so on. You're not going to prescribe opioids for neuropathic pain, for example. Versus if you have someone who has cancer and they have nociceptive pain, and now they are experiencing significant amount of pain and they're coming in with severe pain, maybe opioid is going to be a better alternative for them depending on the classification of their pain. So acute pain, again, is usually associated, like we mentioned, with an acute physical condition. There is usually an association. So there is usually an etiology that you are able to identify why patients are experiencing acute pain. Generally, it's very self-limited, resolved with the underlying etiology resolving. It's oftentimes nociceptive in the sense that you have either nerve tissues or nerve injury, but may have also chronic in nerve injury. So you can see patients developing chronic neuropathic pain, even though it started as acute. And also it's a symptomatic response that you see an increase in patients who have acute pain. You see an increase in their blood pressure, increase in their pulse, which is an autonomic sympathetic nervous system response. And just keep in mind that failure to treat acute pain properly can actually lead into a chronic pain. Versus chronic pain here, it differs from acute, that it's no longer serves as survival or beneficial purposes. So you have patients who develop pain that goes beyond the acute phase. So we're talking about like 3 months or more. It may persist because of a chronic ongoing tissue pathology. So you see that in patients who have degenerative joint disease, or someone has chronic pancreatitis, or patients who have cancer that spread beyond the curative illness. So we see this very common in cancer in patients who have metastatic cancer disease. And also thinking about the biopsychological effect of pain. So not only the pain now, they have the physical damage, but again, you start to see the biopsychosocial phenomena where patients have sleep disturbance, they have anxiety, depressive symptoms, and so on. So in order for you to treat something, you going to develop what we call the cornerstone. So it starts with doing a proper pain assessment. So asking patients about their pain, asking about the quality, asking about what triggers the pain, if they have any past medical histories of some sort to try to find the etiology of the pain. Then you're going to develop a treatment plan tailored for that specific patients, tailored based on their past medical histories, tailored on their insurance, and tailored on, for example, if they're going to afford the therapy or whatnot, screening for drug interactions and so on. You're going to also provide a lot of patient educations with the goal that you're doing two things. Number one, increasing function, but on the same time, decreasing pain. Specifically, when you're dealing with patients who have like acute pain or chronic pain, and you have a source here that you can potentially like fix or reverse. A number of pain assessment tools that you can do. We have here the two common scales that we use them in clinical practice. We have the unidimensional scales, and then we have the multidimensional scales. And one thing to mention here with the unidimensional scales, they only measure one factor, which is the intensity of pain. They don't address anything else. They don't address the location of the pain, the nature of the pain. They only address how intense is the pain as that particular moment. So we know we have the numeric rating scale, we have the verbal rating scales, we have the visual analog scales, we have the face pain rating scales that we use mainly in children. And then the multidimensional scales, which is pretty much more, we use it for patients who have chronic pain. And this gives more of a comprehensive assessment. Here you are asking patients a detailed questionnaire, asking them about the nature of the pain, the intensity of the pain, the location of the pain, also the impact of the pain on the patients. So how is it affecting their sleep, affecting their mood? It tells you from the name, multidimensional. And we use that again, in particular in patients who have chronic or persistent pain. Part of the assessment also is to ask about the functional assessment. So you're asking about other symptoms, asking about sleep and appetite, waking up time, lifting time, physical impairments, if any, and also the psychosocial assessment that's often done by a psychologist who's part of an interdisciplinary team, or done by a social worker, asking about any kind of depressive mood that resulted from having chronic pain or pain that's not treated appropriately, ability to work, housekeeping, asking also about past medical history of any other illnesses, financial impact, cultural influence, beliefs, and so on. And here's the famous numeric pain assessment that we use when we ask patients, when you interview patients who are coming in with pain, that you're asking about what makes the pain better or what makes it worse, the quality of the pain, so how does it feel like? Here you try to identify what are you dealing with. You're dealing with nociceptive pain, you're dealing with neuropathic pain, you're dealing with central or peripheral, you're dealing with vascular pain or ischemic pain and so on. And you're asking patient also about the radiation of the pain. Is the pain localized or that spread, it shoots someplace else? And the severity, like how severe is the pain throughout the day? And asking about the time to try to identify, is this an acute pain as a result of a tissue injury or something that happened recently? Maybe they recently underwent surgery. And also finally, you're asking also about the impact of pain on that patient in the sense of their sleep and so on. When we think about addressing pain or how do you treat patients, specifically in a chronic pain, we do what we call a comprehensive chronic pain and patient engagement in pain management. And our goal is to restore function, but also improve the overall quality of life by reducing pain and by also cultivating the overall well-being. So while we're addressing physical, so patients complaining of a specific symptom, specific like pain, and they're saying like it feels like throbbing, for example, or tingling or burning or so on. Here we're going to use our polypharmacy by medications, using like our NSAIDs depending on the type of pain, anticonvulsants, opioids, and so on. We may also refer patients to an interventionalist to do a procedure if the patient is in a specific area. So they can either get like a nerve block or a steroids injection. So for example, if someone has facet joint disease, rather than giving them oral therapy or polypharmacy, maybe we can do a block for them, or maybe they can get trigger point injections of some sort that will help alleviate the pain. And also the psychosocial behaviors by referring patients to psychologists and social workers to address any issues or to do cognitive behavior therapies. And if patients have substance use disorder, to work with the substance use disorder specialists to address these maladaptive behaviors. Some of the options when it comes to pharmacological point of view, so we're going to, depending on the phenotype, again, we're going to either use NSAIDs. So for someone who has like bone pain, for example, anticonvulsants, they are commonly used for patients who develop neuropathic pain, muscle relaxants, someone has muscular pain, vitamin D deficiency. There are a few studies now that note patients who have a low level of vitamin D can actually experience various types of pain. So it's worth a trial to check patients' vitamin D and to see if they have a vitamin D deficiencies, and if so, to address it, because that could help with managing their pain. Antidepressants, in particular for patients who have neuropathic pain, and opiate analgesic, which are reserved for patients who have severe pain, and in particular in the cancer patient population. In terms of non-pharmacological options that could be incorporated in pain management, we can use heat or physical therapy, depending on the insurance. And that's really the dilemma here, that oftentimes you hear that from patients, my insurance is not paying for physical therapy, which becomes problematic in terms of addressing their pain in a non-pharmacological fashion. We can do, again, cognitive behavior therapy. We can do, research has found that exercise also can help reduce pain, specifically in patients who suffer from osteoarthritis, or patients who have low back pain, or patients who have neck pain, or patients who have fibromyalgia. Yoga also, and relaxation techniques, flexibility. These can also be good tools for managing chronic low back pain in patients who have fibromyalgia or chronic low back pain. Sleep evaluation as well. And again, referring patient for interventional pain specialist. Just very quickly to talk about the category of opioids, if you decide to use them for patients who experience severe pain, and also in patients who have substance use disorder, here we're going to try as much as we can to avoid our short-acting medications. And opioids in general are divided into two categories. We have drugs that are meant to be used for intermittent, or what we call breakthrough pain, in the sense that they have certain benefits. They're easier to titrate. They're more rapidly attained to steady plasma concentration, steady state plasma concentration. And we have a lot of them on the market. We have morphine, immediate release. We have codeine that comes in combination with acetaminophen. We have hydrocodone. We have oxycodone. We have fentanyl, oral transmucosal substance, that are only reserved for patients who have cancer breakthrough pain. And we have different types on the market. We have the lozenges, we have the tablets, we have the sublingual tablets, we have the nasal sprays. And again, they are only reserved for patients who have cancer breakthrough pain. They're not for chronic non-malignant pain. We have also hydromorphone and oxymorphone. And then we have long-acting opioids that are meant for chronic pain in patients who have consistent pain. They are better options for someone who has substance use disorder, or for someone who has chronic pain that went beyond the normal course of an etiology that could be fixed. And here we use this often in patients who have chronic metastatic disease, in cancer patients. And we have an idea here of using a longer acting that you are meant to be taken around the clock. And dosing convenience, they are relatively steady state concentration of opioid concentration in the blood. We have a couple of them on the market. We have morphine extended release, oxycodone extended release, transdermal fentanyl, hydromorphone, methadone, and so on. And irregardless, anytime that you're going to use, whether it's a short acting or a long acting, here we're going, and you're going to hear more from my colleague about stratifying the risk, identifying if patients are a risk factor for developing opioid use disorder or opioid dependency. So you're going to ask patients if they have any kind of personal history of substance use disorder, family history of substance use, if they have any kind of legal history, if they spend any time in jail, if they have any kind of mental health disorder that's not addressed, and so on. So just very quickly also to define these three terminology, and I'm not going to spend a lot of time about addiction because you'll hear that from my colleague. Physical dependence is a phenomena that happens when patients who are taking opioids chronically. They can develop this when your body starts to rely on the drug. So if you were suddenly to stop the opioids, patients are going to experience harsh symptoms. So this is why if you going to have any patients on chronic opioids and you decide you're going to taper it, you're going to stop it, it's highly recommended that you taper them. Otherwise, patients are going to withdraw, which is very uncomfortable for a patient. Opioid tolerance, which is characterized by reduced responsiveness to an opioids agonist, such as morphine or oxycodone or any derivative. And it's usually manifest by the need to use increasing dose to achieve the same desired effects. This usually happens because you have what we call an opioid receptor downregulation, which contributes to the opiate tolerance. So don't be surprised that after a month or so, patients come and they ask for an increased dose. And just be very mindful, are they developing maladaptive behaviors? Or now we are going into what we call like the danger zone. And you have to be very close attention. Are you dealing with tolerance or are you dealing with something else? And addiction, which is a long-term brain disease that could develop. Here, patients are considered to be highly treatable. However, it takes few trials of therapy to fully find the effective dose for the treatment of addiction. And just like any other disease, it has relapses and remission, and my colleague will talk more about this. And just how do you decide to choose an opioid in a patient? There are a number of factors that you're going to rely on. So what's the pain intensity of the patients? If the patient has any coexisting disease, so maybe certain opioids are actually contraindicated or preferred not to be used. So for example, if someone has renal impairment, we tend to stay away from morphine, versus if someone has hepatic dysfunctions, we tend to be careful about using any opioid that relies on the liver, so like methadone or fentanyl. We also take into consideration the patient response to the previous opioids, thinking also about the pharmacokinetics of the opioids. So are we going to give, depending what the patient is, are they in the emergency rooms? Are we going to use intravenous, subcutaneously, or the patient in a home setting, or the patient in a clinic setting? Are we going to use oral? Also, with a certain type of oral, we're going to use immediate release, or we're going to use extended release, or so on. And taking into consideration also the formulary consideration, like what the insurance covers. And very quickly, assessment of addiction risk, which my colleague again will go over it, is we rely on, there are many tools out there, but we really rely strongly on good clinical history, taking skills and risk factors. So there are a number of risk tools and risk tools that you can use out there. The easiest is the opioid risk tool, which is a 5-item initial risk assessment that asks patients about their family history, asks about their personal history of substance use disorder, asks them about their age, if they have any kind of sexual abuse, pre-adolescent sexual abuse, if they have past or any current of psychological disease, and then stratifies the risk into low risk, moderate risk, and high risks. Also, let's not forget about the genetic factors and predispositions, and also the social and familiar circumstances. Let's not underestimate the social peers that could also play a risk factor for patients to develop addiction. And if you're going to give patients, a patient specifically have opioid use disorder, and you're going to treat their pain, one of the main goals that we're trying to do is to prevent withdrawal, also provide effective analgesics, prevent relapse to addiction, but also provide effective treatment of opiate addiction by providing the right maintenance opiate therapy. And if patients develop any psychiatric disorders, to treat, like such as anxiety or depression, is to treat that properly. So just very quickly talk about the opiate pendulum. So back in the 70s and the 80s, we were in the phase in the United States, we're in the avoidance phase. We had a lot of opiophobia, which is the rest of the world stuck in that phase right now. And then unfortunately, in the 1990s and the early 2000s, we had opiophobia due to pharmaceutical companies lobbying for increased access to opioids and claiming that opioids could be used for all condition, which is not the case. So we had opiophobia, and now the pendulum is pretty much shifting back to avoiding using opioids. So I get that question often: what should we use? Should we avoid using opioids all the time, or should we feel safe about prescribing opioids? And the right answer is using balance. You know, opioids are definitely not indicated as first-line therapy or even second-line therapy for certain conditions. They are necessary for patients. They are indicated for other conditions as first-line therapy, specifically in the cancer patient populations who experience severe pain. But while we're also teaching about opioids, I think it's highly important to teach also about the principles of addiction, to educate physicians about opiate prescribing, how to safely prescribe opiates, how to make sure that you are not causing harm for the patient, but also addressing pain. So I feel like right now we have two pandemics, the pandemic of the opiate overuse, but we also have the pain pandemic, in the sense that a lot of patients are not getting their pain properly treated, or they actually being pushed by specialists or primary care because of this fear, of this notion of fear of prescribing opioids. And just very quickly here, pain behaviors versus suspected behaviors. So when someone has a disease of addiction, where now they have impaired control over drug use, they have compulsive use, they have craving, versus the disease of pain, Is it really drug seeking versus seeking relief for pain? So we have to do a thorough job to identify what is going on here. Are actually patient drug seeking, or are they actually seeking therapies for their pain that's not being addressed or being undertreated? So just very quickly, one of the tools that's just part of the course is universal precautions in pain medicines, that we constantly have to reassess pain scores and functioning. We have to limit the amount of medications prescribed. And specifically, patients have substance use disorder. We can do random pill counts. We can rely on assessing what we call the 5 A's, so analgesics, activity, adverse reactions from the opiates. Make sure that we are monitoring also any kind of aberrant drug-related behavior, adhering to the treatment regimen, and review the pain diagnosis and the comorbidities, and making sure that we also document them. And here we have switching gear a little bit to talk about the importance of urine drug screening. It has shown that it improves patient safety because it also performs better than physician impressions. It has two folds. One fold is to make sure that whatever I'm prescribing as a clinician, patients are actually taking. The other fold is that misuse testing. We are making sure that patients are not taking something that I'm not prescribing, or taking something that's not being prescribing for them. So we have two tools right now that we use in clinical practice. We have the screening, which is the cheapest, which is an enzyme-mediated immunotest, which is a qualitative, positive or negative. It just tells you if it's there or not there. It's sensitive but less specific. Then we have the confirmatory one, which is a gas chromatography, which is more expensive, which is quantitative, it's sensitive, it's more specific. It screens also for other opioids other than true opioids like morphine and codeine. It screens for other specifications of opioids like fentanyl and methadone and oxycodone and so on. And just very quickly, let's not underestimate the benefit of using adjuvant analgesics also for the treatment of pain. Oftentimes we think it's all opioids, which is not necessarily the case. We should take advantage of the multi-purposes analgesics like corticosteroids, who are known to be commonly used in patients who have nociceptive pain. So patients who have bone pain, secondary to like a fractures of some sort, or secondary to like cancer. The antidepressants, again, for neuropathic pain, the cannabinoids, who now are indicated for different types of pain, specifically neuromuscular pain or also neuropathic pain. Also drugs that could be used for neuropathic pain like anticonvulsants and antidepressants. And just in summary, also the role of patient education in pain management, which is a very critical component of effective pain treatment. We need to educate patients, increase patients' understanding of the etiology of pain, understanding of the pain treatment plan, the importance of adherence to the analgesic regimens, and provide information for patients and their caregivers, and writing, encourage questions, involve the caregiver and the family members. And teamwork with the pharmacist. The pharmacist is a critical member, especially if you're going to work in a pain clinic or a pain hospital, or you're going to be serving as a consultant in a hospital, whether you work in palliative care or acute pain service. We should have an open dialogue between the prescriber and the dispensing pharmacist to minimize the risk while enhancing patients' care. And the pharmacist, due to the fact that we studied a lot of pharmacology, we can offer a lot of insights and help clinicians modify treatment plan by ensuring pain is adequately addressed by knowing the treatment options and how to utilize them. So in summary, acute and chronic pain syndromes are prevalent among patients with multiple conditions, including chronic and non-malignant pain. Having a good understanding and knowledge of the multidimensional nature of the physiology of the pain, and understanding the pain and the addiction, also how there is a relationship in there. Best practices recommends a comprehensive approach, not only relying on pharmacology and polypharmacy, but also using multimodalities of care to address pain in patients who suffer from pain. And that's all the time I had. Now I'm gonna shift it on for my colleague who's going to talk to us about substance use disorder.
All right, thank you so much. I'm going to just jump right in for the sake of time here and talk a little bit now about substance use disorder and how we will approach this in the patient with pain. I want to just kind of hit home a few concepts here, and I'll try to highlight these as we go through the next few slides. But here is I try to break down the DSM-5 diagnosis of the of a substance use disorder. So trying to put them in different categories to break it down more, because sometimes the DSM-5 can be pretty heavy. So we look at these 4 different aspects with impaired control, social problems, risky use, and physical dependence. So one of the things I like to drive home is that this is a disease state. Like we had talked about before, I talk with a lot of patients and colleagues and talk about what substance use means, opioid use disorder means. And a lot of times there's this sense that, unfortunately, still that this is a choice, right? And there's a lot of risk factors that play into the development of this disease. But one thing I at least want to highlight quickly is that people might enter this and have this diagnosis and enter it for a variety of different ways, right? I never say there's no aspect of choice here, and it's more of a spectrum. So I equate it to a little bit like type 2 diabetes. I use a lot of analogies here, so just bear with me for a second. With patients with OUD, you have some who will develop it based off of genetics or other risk factors that they have limited control over. So maybe they're prescribed opioids as appropriate, and it later turns into more of a dependence tolerance and then a use disorder. Other people may start engaging in illegal, illicit use, non-prescribed use, and that may then lead to an opioid use disorder. At that point, it's no longer a choice. So I try to compare that to similarly with type 2 diabetes. You have some patients who are more predisposed to developing the disorder, and those who maybe will start making a little bit unhealthful choices and over time lead to the development of that diagnosis. But either way, we got there. So this is a real disorder. And I do try to break it down on the next slide by the ABCs of addiction. So an easy way to remember it, the way that I work with students is we think about abstain, so inability to consistently abstain from use, and impairment in behavioral control, craving, diminished recognition of all these problems. So it's affecting their daily functioning, and this emotional response, dysfunctional emotional response. So their whole world is revolving around when that next time they're going to get that substance. Some of the risk factors have already been pointed out by my colleague, but I'll just highlight some of these are more demographics and probably not too surprising. The one that I always highlight, though, is the genetic risk. Up to 60% of the risk to develop a use disorder can be linked to genetics, which is insane. Again, kind of shedding light on the fact that this is a disease state, and oftentimes there's a lot less control than we perceive there to be. So talking about this with providers, with colleagues, with patients, it's important to remind them that a lot of environmental factors can contribute, like added stressors, et cetera, but there's a lot of genetic risk too that we can't necessarily control. The next few slides go through just some numbers that talk about just how bad is this epidemic, what are people using, et cetera. So these are all from a SAMHSA report from 2020, looking at this one specifically looking at the number of illicit drugs users among people aged 12 or older. You can see the majority are using marijuana out of this 21% of people, but that second one is a 9.3 million using pain reliever misuse. So it is still a very high number, and you can see the bottom there, you can add an additional 902,000 for heroin being another opioid. Just to frame it, here is a graph that shows what is causing these overdose deaths. As you can probably guess, synthetic opioids are the methadone, primarily fentanyl, being the extremely strong opioid, whether they're believing they're getting fentanyl or it is unfortunately marketed as something different, and then they are ingesting it or taking it, whatever route of administration, and then leading to a very risky overdose situation. It's still primarily fentanyl here. The next two slides are looking at the perceived need for substance use treatment among those patients who did not receive substance use treatment at a specialty facility in the past year. So I do this because, or show this and talk about it, because 100% of these people on here, this 38-ish million, were shown to need treatment, right? But only a fraction of them really even thought they didn't need it at all, or that you can see 211,000 felt they needed treatment and made an effort to get it. That's a very low percentage. 737 patients felt they needed treatment and did not make an effort to get treatment. So only that 2.4% of patients actually believe they needed treatment, and whether they sought it or not, differences. But the vast majority of those patients who are qualified for treatment, who do need treatment, do not recognize that. So there's a huge gap there where we can all play a part in trying to more normalize and talk about this, because this could go hand in hand with pain as well, because there's a lot of overlap, as we already talked about, and we want to make sure that we're not only treating one without the other, because otherwise we can't really be effective. And even if we do not treat either of these conditions, we can make recommendations for referral, ask the questions that help normalize it a little bit more, to help try to engage more people in use disorder treatment. This slide is now looking at the reasons that they believe they did not need it. So it kind of gives you, this is from 2017, this kind of breakdown, but I wanted to just kind of be comprehensive and show some of the reasons that they quoted as to not needing treatment. So not ready, no health care coverage, might have a negative effect on their job, did not know where to go, did not find a program that offered type that they wanted. So you can see how that breaks down, and we can use this information to help guide our conversations with our patients. So talking about intoxication and withdrawal, these probably symptoms are not a surprise to anyone, so I will not focus too much on it here. But the intoxication, as we can imagine, leads to more sedating effects, so drowsiness, coma, and more severe situations, respiratory depression, pinpoint pupils. And then the withdrawal portion of it that we can recognize is more of this discomfort, dysphoria, nausea, vomiting, myalgias, diarrhea, sleeplessness. And so a lot of that obviously drives that continued use to avoid withdrawal too. And to throw in a rating scale here, the way we do assess withdrawal is with the COWS, the Clinical Opiate Withdrawal Scale. And this is just, I wanted to flash this up here to say, of note, we can utilize this in usually inpatient settings, but also outpatient settings if we're trying to initiate treatment, especially to make sure that we're in line with recommending starting, say, a product like buprenorphine Suboxone product. And then I'm hopeful, and I'm sure people have heard of SBIRT here. So SBIRT is a comprehensive approach to the delivery of an early intervention and services for those persons with use disorders who are at risk. So trying to engage more patients in care. There is a great landing page where even if you just Google SBIRT, it will bring you to a lot of different assessment tools for a variety of different use disorders that can help make that clearer and that guide the conversation with a patient so we can refer them to more treatments if needed. All right, so I wanted to spend a little bit of time on treatment guidelines and just review how we treat substance use disorders before we talk about some of our cases and really drive home some of the important, I think, pearls about these so we can help more patients become treated. So first line, as we probably all know, for the intoxication or overdose situation is naloxone, and you can get those at any pharmacy, and usually they're going to be covered up to a $40 copay if there's a copay there at all with our NCAP program or the naloxone copayment assistant program, and it's all in a standing order, so you can just go to any pharmacy and ask for it. I highly encourage anyone to really talk about that, and it still boggles my mind that some people have stigma around naloxone, so we take that into mind. We're talking to people that some people, when we talk about naloxone, think we're saying, oh, you're going to overuse, and it's like a fire extinguisher. We don't expect an overdose to happen, but it's really just in case it does, right? So, and when I talk to patients, it's more talking to them about how it's not really for them per se, it's for everyone around them. If someone is in an overdose situation, they're going to be incapacitated to the point where they can't use it on them, right? So we carry it for everyone around us, as well as if the more people we tell that we have it on us, if we get ourselves into a dangerous situation for whatever reason, then we also can have that to help. For dependence, and withdrawal, we have our mainstays of treatment, which is the buprenorphine and methadone products. I'm going to talk a little bit about them specifically in the coming slides. And then I will mention briefly the naltrexone IM, which is for more motivated patients, but has the least amount of restrictions in its use in patients, so can be an option for some patients. So the next few slides just go and break down the three different options that I already highlighted here. And you can see the methadone and buprenorphine I'm going to focus on first, but we go through the next few slides and all side by side here. Methadone and buprenorphine are probably the ones that we're most familiar with. And I'll start with methadone going down, that this is a mainstay treatment that's been around for years and decades, and it's been very effective at decreasing cravings as well as relapses and overdose deaths. This is probably the most restricted medication out there, and it is going to be only given to patients with substance use disorders within a designated clinic. So an opioid treatment program is what that OTP stands for. And in order for a patient to become enrolled in that, they have to go to the OTP or be referred there, and they may have to go there every single day. So when I worked in the methadone clinic, it was a very early morning because people with their daily routine need to incorporate that somehow, but they can't kind of show up if they have work, et cetera. So it can get in the way that a little bit that way. But again, we need to have that specific program available to them. And some patients will actually like that, prefer it, because it does engage them more in care every single day, and they have more of a comprehensive approach with some therapists, et cetera, there to help in their recovery. Buprenorphine is a partial agonist, which binds very tightly to the opioid receptor. And so I mentioned a little bit about the cow's withdrawal scale, needing a little bit of withdrawal so that we don't actually initiate withdrawal in them. If someone's on a full agonist and we give this medication, it can actually put them into withdrawal. So I try to say, get to a patient to being a little uncomfortable, not vomiting excessively or feeling very uncomfortable, but get to a point where now, instead of going from, say, a full agonist down to the partial, I allow them to withdraw a little bit and then I push them up to that level. This is a more accessible medication. However, it still has restrictions, unfortunately. The patient can pick it up from an outpatient pharmacy, as probably many of you know here. There's a variety of different formulations, as we'll go into too. But with a provider who is equipped and licensed to prescribe it, that can go right to that pharmacy, and they don't have to go to a special clinic, which could also release some of the stigma around it as well, because they're going to just another pharmacy. But it does not have necessarily all those other resources like a methadone clinic will have. So the other point that I want to make about buprenorphine is talk a little bit about the X waiver, and we will talk about it a little bit more. But the X waiver is the indication that a provider can prescribe buprenorphine products to the pharmacy. They need a special certification, which until this past winter required MDs and DOs to do 8 hours of training to get that designation, or 24 hours of training if they were advanced practice healthcare professionals, like a nurse practitioner. Since then, and by that I mean this past winter, there was a notice of intent document sent out, or more of an opening to get more providers involved. So the SAMHSA put out this ability for any provider, what level they're at, to submit an NOI, notice of intent, that they would like to prescribe buprenorphine, and they are able to have that reviewed and get an XDEA license without any training. They can only prescribe up to 30 patients or carry 30 patients on their panel. However, it does increase the access to this potential life-saving medication. It still does restrict it, though, because you can't just go and prescribe it, right? There is an emergency clause where you can try to get it for an emergent patient right in front of you, but it's moving in the right direction, but still has some restrictions. Naltrexone is the only one without any restrictions, does not have as strong, compelling data as the others, being an antagonist, but there is some data for the IM formulation to be able to decrease relapses, decrease overdoses, decrease use. So it does have the ability to help patients who may not have access to these other two options. Here are some of the possible side effects, which I'm going to kind of not read fully here, but highlight a few just for sake of time here. So the methadone, the biggest one is the QT prolongation. We want to make sure we're monitoring that in our patients and taking that into account at baseline, maybe monitoring the potassium, magnesium levels. Otherwise, the other two are pretty well tolerated. I will focus on, or at least highlight, the implant and the subcutaneous injection for the buprenorphine products. These are two newer formulations. They both have had pretty good success in practice that I've seen with some of my colleagues who are treating patients. But I'll tell you a little bit more when we get to those slides in a little bit more detail, because they are newer agents or newer formulations. These slides go through more of the evidence in opioid use disorder. Again, I already highlighted the biggest thing I want to take home here is that naltrexone is reserved for those motivated OUD patients, but has the most accessibility if we have no access to an opioid treatment program or a provider who has an X waiver to do that. And this slide is to give you a little, it's an excerpt from a SAMHSA publication, tip 63, which goes through some of the variety of formulations we have for buprenorphine products. Some of them come with naloxone, some of them don't. And I know there's some confusion in terms of what dosing I utilize. So this is a really cool resource you can utilize if needed for using any type of Suboxone or buprenorphine product in practice. So talking a little bit about the other buprenorphine products I highlighted, the implant is a newly approved as of 2016, so not extremely new, but still new. And this is indicated for patients who are stabilized on low to moderate doses of transmucosal buprenorphine. So what I mean by low doses, it's usually 8 milligrams per day of the buprenorphine product. That's a very low dose, which I would say not many patients are maintained on that. So the applicability here is limited to patients who, again, are on a lower dose. You can't try to lower a dose to get there because you risk a relapse if they're not fully covered by 8 milligrams. So this one has a little bit of a harder application, but still is great for some patients. And this does consist of 4 implants inserted subdermally in the upper arm for up to 6 months of treatment. They come back in, it's a small surgical procedure. They get it in the other arm, upper arm. After that full year of treatment, they say to go back to sublingual. So I don't know of anyone probably go back to the other arm, but the package insert still states to go back to an oral or sublingual, which if I were the patient, I'd probably be a little frustrated with, but it has been done successfully in some clinics. The Sublocade product, the buprenorphine injection, is a once-monthly injection, which can treat patients with more moderate severe OUD on higher doses. So this range for patients who are on 8 to 24 milligrams per day, I would say the bulk majority are either on 24 or right around there. So this can apply to, I think, a greater range here. It's a monthly injection, like I said, and it has a dosing of 300 for the first 2 months, and then you can go down to 100 milligram dose or stay at the 300 depending on patient response. But this is one that I'm sure we'll see more of as long-acting injectables are just more increases adherence and increases overall outcomes in general. Treatment algorithm. So this is a very simple slide. I wanted to just drive home the fact that recovery and treatment for SUD or OUD is lifelong. We do have, say, this withdrawal treatment for 7 to 10 days where you minimize the withdrawal symptoms and then get on a maintenance of either methadone or buprenorphine, but we do not have a time limit on that. The guidelines state patient specific, so some may be on that for lifelong, and it's okay to do that. And no matter where we are in practice, we can normalize that for our patients, because I think that when patients hear us say, oh, you're still on that, or oh, are you getting down off of it, that implies that they should be doing that. Some are motivated to do that and they do fine on that, but it's not expected of all patients. So it is okay to be on this for lifelong. And the more we talk about it, normalize it, the more hopefully better patient outcomes we can see. For reference, here's some adjunctive treatment, which does not have any restrictions. The only additional add-on here would be lofexidine, which is a more specific alpha-2 adrenergic agonist, but it has minor benefits over clonidine, and clonidine is much more affordable. So usually we're going to still be using clonidine for some of those other opioid withdrawal symptoms if we don't have access to more of the specialty medications like buprenorphine and methadone. And one last thought before we highlight some of the cases at the very end here and answer any questions I can see popping up. Always encourage our patients when they're done on a short-term course of opioids, no matter what the indication, to dispose them in a safe medication disposal method, whether it's a box or a take-home event or some of those dispose RX packets. And I would encourage all of you to talk with your colleagues to see what options are available at your practice. And with that, I'm going to invite my colleague back to talk about some of our cases and some questions here too.
Hi, Bennett, I'm back.
Yep. So we're going to go through a few cases, and maybe while we're going through this first one, we can both review some of the questions that came in as well to make sure we answer some of those. But I'll read the first case. This is a 30-year-old woman with a history of recent intravenous drug use, admitted to observation for IV antibiotics. After the incision and drainage of an antecubital abscess, she has a history of opioid and cocaine dependence. She receives IV morphine, followed by IV hydromorphone for acute pain. As she had a significant debridement performed after this procedure, she's demanding increasingly higher doses of IV opioids, and the observation unit team is becoming uneasy regarding the dose and frequency of opioid medications she is receiving. The nurse raises concerns that she has tampered with her IV tubing and may be using her IV to inject something. So we wanted to bring this case up, this small vignette up, because we wanted to really drive home, number one, how do you approach this case? And then some of the main, I guess, themes of potentially needing higher doses of opioids than maybe we are comfortable with patients who are dependent. So I don't know if there's any thoughts that anyone wants to share about how they approach this case, but I'll give some space. Anyone wants to type anything in the chat, or if you have anything to add, Sammy, right now.
Yeah, it's exactly what I want, what you said. Let's see first, how do you approach this case? Now you're dealing with someone who has a history of opioid and cocaine dependency, but on the same time, they're having acute pain. So how would you address this pain? How would you manage it? Specifically when you have nurses who are telling you that they are susceptible of what patients are doing, in the sense that they might be tampering with their IV tubing and whatnot. So what should you do in this case, in a case of acute pain in the presence of a history of opioid use and cocaine dependency? Let's see if someone typed anything.
So yeah, this first case was really to highlight the fact that someone may need higher doses, and that's okay depending on their tolerance level on medications. And we need to make sure we're individualizing those treatment algorithms to the patient in front of us versus just what has been done before. And I was going through some of the questions here, which I will just, again, for sake of time, go to the next case because it does illustrate some of these questions. Someone had asked about the scenarios where there's an exception to the X waiver. So I believe this is the case that goes through one of the exceptions that I want to highlight, and I want to also highlight the 3-day rule. So a 20-year-old man is brought to the ED here. His family reports that he failed at the school in his second year at a community college. He admits he struggled with prescription pain pills and heroin use. He has this withdrawal, moderate withdrawal score in the cows, and his providers have clonidine, ondansetron, and the provider subsequently receives a concerned call from the hospital pharmacist because they're unaware if they can prescribe the buprenorphine or approve it through. So this is an excerpt from CFR 21, which highlights that a practitioner may administer or dispense directly, but not prescribe, a narcotic drug listed in any schedule to a narcotic-dependent person for the purpose of maintenance or detoxification. So what does all that mean? It means basically that in that situation where someone is in the ED and withdrawing, we can prescribers can prescribe a buprenorphine prescription if they are treating withdrawal for up to 72 hours. So, and sorry, I shouldn't use the word prescribe, but dispense. So they cannot give them a 3-day supply and discharge them. Let's say they have to dispense directly to them in the ED for up to 72 hours. It doesn't matter how many doses, as make sure they're dosed appropriately, but that can help treat patients in the ED and then hopefully connect them to an outpatient treatment facility after that. When someone is inpatient, there is really no requirements for an XDEA provider and an inpatient unit. I was talking with someone from SAMHSA the other day and who said inpatient, there's no requirement for the X waiver to use a buprenorphine product. So that is another exception there. But the 3-day rule is something that not a lot of people know about, and it is something that we can talk more about because I think this is a good way to start a mini bridge clinic and help these patients who may not be helped otherwise. That's all I have about this case. I don't know if you have anything to add, Sammy.
No, I'm good in this case. So do you want me to take the next one just for the sake of time?
Yeah, sure. Go for, and I don't have the other one actually because the power went out here very quickly. So I had to switch quickly. Do you want to bring up your screen instead?
Okay, let me see. I don't,
or actually,
I
you know
think
what I
I
can
put,
do? I think I can go
yeah,
into,
because I put it in yours. I put it in
Here.
the Google.
Yep, there we go. So sorry, everyone. Thank you for bearing with us. It went off 2 seconds before I started. So
No
here's
worries.
your
Okay.
case score.
No worries. So this is actually a rare case that I had in my palliative care practice where we did have a 55 at the time. We did have a 55-year-old African-American woman with a history of IV drug use back in the 70s who was recently diagnosed with multiple myeloma. She was started in multiple myeloma treatment and she presented to the palliative care clinic complaining of severe mid-back pain. She's been trying to find a pain specialist who would treat her pain, but every specialist has been reluctant to treat her because of her past medical history. At the time when we interviewed her, she stated that the pain was really affecting her overall function. It was causing her to have difficulty falling asleep. It was affecting her appetite, her overall functioning. And the patient actually, she shared with us at the time, and we're able to look it up through our medical record, that she was hospitalized twice because due to the reluctancy of pain specialists to prescribe her medications, she actually went to the streets and she started self-buying opioid to manage her pain. So she was in the clinic at the time, begging us for my palliative care, my attending, to manage her pain. So this is a point that I'm trying to make here, is that we shouldn't be very terrified of patients who have history of IV drug use in the past. You are treating a patient. This patient has a legitimate reason for having pain. Multiple myeloma is a very painful disease. It's associated with a lot of nociceptive pain, muscular pain. Patients do need treatment. It's just that how are you going to treat her? The approach is really the way. So in her case, what we did with her is that we sat down with her, we developed a treatment plan on how we're going to treat her pain. We were very reluctant about initiating short-acting opioids. So we prefer to start with like long-acting opioids in our case, but we also took advantage of the adjuvant analgesics. She didn't have any contraindication for NSAIDs. She didn't have any contraindication for a low dose of steroids. So we relied on that also, in addition to incorporate opioids. We made sure that we designed a treatment plan with her. We made sure that we did urine screen testing every time she comes. And we also at the same time reach out to psych addiction to make sure that she's being followed with them, to tell us if there's any aberrant drug-related behaviors or any issues. So I think we have to, at the end of the day, be mindful that we're treating patients, and we shouldn't be pushing people to go and buy from the streets, because when you buy from the streets, you don't know what you are buying, and that could potentially harm the patients. And Bennett, if you want to add anything here, please feel free to do so.
No, that was perfect. A perfect way to, and again, we can probably talk about this for hours. And I know this is just a snapshot of substance use and pain, but I really appreciate everyone coming today and being attentive. And if we can help and answer any further questions, let us know. But I know we are at our time, so I will a little bit over, so I will stop here.
Yeah, I just want to say thank you so much to both of our speakers today. Really great topic, and I think really insightful comments through the cases. There is in the chat information for how to claim CE credit. And actually, Bennett, if you wouldn't mind stopping your screen share, I was just going to share mine, and then I'd be able to show that here as well. So this is also how you can claim CE credit. This information is in the chat. You have to complete a post-evaluation form, which is the bottom left QR code, and then go to the ACCP website for CE. If you don't have an ACCP account, that's fine. You can create one for free and click Claim CPE for chapter activity. Our code is this NYSCCP 11221. You have to complete that within 60 days of today. So again, to claim the 1 hour CE credit, this is how you would do that. And we'll also try to email this information out to all those that registered and attended today's event. So again, in the interest of time, I thank you both very much. Thanks everyone who attended today. And I really appreciate the speakers and the information that was provided. So thank you. Thank you again.
Thank you very much.
All right. Take care, everyone. Have a great day.
You too. Bye-bye.